نبدأ. Okay. Bismillah ar-Rahman ar-Rahim. We will start the Sunday lecture on tropical medicine, or better, medicine in the tropics. The need to address medicine in the tropics has risen through my work in the international health programs in Africa, particularly the African program of control of onchocerciasis. Okay, we start again. This is yet the other lecture on Sunday, which is on tropical medicine. I would like to rename it into medicine in the tropics, because the classic diseases of the tropics like trypanosomiasis, onchocerciasis, lymphatic filariasis, lowiasis, these are geographically bound to certain areas in Africa. And this is now called neglected tropical diseases, which has been attended to in the last 30 years, and we have seen great successes. But medicine in the tropics is different from medicine in Europe. My interest came through working in international health programs, particularly the African program for control of onchocerciasis, based in Ouagadougou, Burkina Faso, trachoma, mainly in South Sudan, schistosomiasis in Sudan, and other diseases like deworming or worms in Africa. So I felt the need to teach the tropical diseases or infectious diseases, particularly in the environment of the African countries. This is made our interest increased to go to Africa itself, where we're living. We're living in Sudan, which is Africa. South Sudan is Africa. But we wanted to be integrated in the society of Africa, like Rwanda and Tanzania, and to try to be part of the development of medicine and education in these countries. No doubt there is a global demographic shift in population. There is increased displacement, increased refugees, warming is coming up, and great injustice in the world. So the old map of diseases, which is here infectious, tropical, and there diseases of civilized, affluent population, is no longer holding. And the pandemic of SARS-CoV-2 or COVID-19 has shown us that there is no respect to boundaries as far as infectious disease. And COVID itself has unified and united the world to the fight of the disease, to the extent that if there is a new strain in South Africa, the American will get interested more than if it is in Iowa state, because they know that the day it appears in South Africa, the second day will be in Texas. So that is the unification. But unfortunately, when the vaccine came, it favored those who have and left those who haven't, to the extent that it has been distributed, highly distributed in Europe, America, Australia, Canada, and many African countries were left without vaccines. So the world now is worse than it used to be. The world is worse, with wars breaking all over. Even Europe, which was thought to be safer, now there is war there. Inequality and inequity, inefficiency and incompetence, and biased judgment, particularly from the North against the South. Has shown itself negatively on the health programs and the health of the African countries. So we need to address the necessities of medicine in Africa. And since now we have been part of this society, we need to teach the tropical medicine, infectious diseases in the context of these countries. Where do we go now? There is a dilemma. Whatever we do, whatever we develop, then one war can break it all. Just suffice to say that the Eastern Mediterranean war, which is now current, has killed more than 50,000 people in less than 3 months by bullets. So it's even more than any infection can do. But anyway, you have to live with it. So I would like you to reorient yourself regarding the infectious disease and tropical disease. This has no boundaries, okay? Africa will very soon, in the coming 20 years, will be rid of the classic tropical diseases, which is worms related. But we will remain with infectious diseases, which may be of high burden in Africa, but also it is prevalent in other places of Africa. And the factors of economic, social, cultural factors are mainly in action with this disease. Okay, let us turn to today's lecture. And we started the lecture the week before last on hematological abnormalities or hematological diseases in Africa. Okay, this will encompass anemia, okay, hemoglobinopathies, which include mainly sickle cell disease and thalassemia, and we'll look into abnormalities of white cells, particularly neutrophils and platelets. Okay, cancer is cancer everywhere, but there are peculiarity to cancer in Africa. Okay, as far as anemia is concerned, this is a very common disease, and we reckon that at least 2 billion people all over the world are anemic. I would like to remind you strongly that anemia is not a diagnosis, it's a clinical picture, the clinical manifestation or a secondary presentation of a disease underneath. So unless you address the underlying disease, you will not get with a proper diagnosis and proper treatment. So 2 billion people is quite a lot of people who have anemia for various reasons. At least 1.5 billion of them live in less affluent countries, or mainly Africa and Asia. So we'll say that 85% of all those with anemia are living in Africa and Asia. Does it do harm? Yes, it does. Even anemia as by itself, as a complication of disease, can do harm and can affect morbidity and mortality. We estimate that 100,000 ladies, pregnant ladies, maternal deaths is due directly to anemia. So a lady who has anemia has a very high chance of dying, because of that. And at least 600,000 child dies in perinatal period because of anemia. So it is a real concern. It's a real concern. So what are the different causes worldwide and those relating to the African countries? Let us say that hemoglobin RBCs are formed in the bone marrow. So that is number one. It's the site of manufacturing, and the site of manufacturing need to be healthy. So if you have any disease of the bone marrow, then either displaced by tumors, masses, or by fibrous tissue, or by whatever, then the factory will not be efficient, and this is what we call myelodysplasia. Okay. Secondly, we need nutrients to make the RBCs, and these bile enlarge iron, and then folic acid, B12, vitamin A, and copper or copper. These are the essential nutrients which are needed to make the RBC. The RBC lives for 120 days, breaks down into different parts. The protein, the globin was recycled, iron will get recycled, and so on. So percolates within the RBCs because it's a concave structure. It has the easiness of going through the capillaries, going through the tissues, and helping providing oxygen. So the sustained development goals, which replace the international development goals, puts anemia under the poverty, and this is accepted because the majority of cases of anemia are due to nutritional deficiencies like iron and folic acid. So it's the bone marrow will definitely work with efficiency under a hormone called erythropoietin, which comes from the kidney. And here the kidney acts as an endocrine organ, but erythropoietin comes under the release. The erythropoietin will be under stress of hypoxia. If there is hypoxia, erythropoietin will go out and acts on the bone marrow to produce the RBCs and activate the bone marrow for not only the hemoglobin but others. If renal failure occurs, then erythropoietin will be depressed or decreased. And this is why patients with renal failure needing external erythropoietin. So, having done that, the RBCs are formed, distributed, and it goes on. Okay. The anemia is an indicator of health. We have to accept that fact because we need indicators of health like weight, anemia, stature, cognitive function in children. All these are indicators of health. Surveillance of health, especially if you have a program of health in a community, what are the indicators which you use to tell if your program is doing well or not? Okay, why anemia? Anemia causes morbidity. So, and it is common in a lot of diseases, infectious diseases, and worms, all right, nutritional. So if the hemoglobin goes up in a community, then something good is going on, like deworming, all right, or like fortification of food by iron or folic acid. So it's an indicator, and more so, it was a qualitative, objective indicator because you can measure hemoglobin very easily, even in the remote areas, remote villages, by a color, comparison of color to color, the color of the blood of the patient against the standard color, as in a method called Sally's method, and in HemoQ method, which may need batteries, but it's efficient. It's efficient and tells the hemoglobin very well. So it is an objective measure of uh, uh, of of health. So deworming, deworming meaning that you are applying a drug. Everyone in the village is receiving it, okay, where the prevalence is high, not examining each individual to give him the drug, but deworming goes what we call mass chemotherapy. Mass chemotherapy is giving everybody in that community if the prevalence is more than, say, 40%. So it's the deworming. We can measure the goodness of the good deworming by doing hemoglobin. So it is an important aspect of measuring anemia. Anemia need to be examined laboratorily by laboratory because clinical assessment of anemia, although as important as it is, but it is not very accurate, and you miss pala, which is the conjunctiva, the mouth, okay, the tongue. These are the areas which you will go. If you do the conjunctiva alone, you are less precise. If you look at the tongue and the mucosa, then you add your precision of the clinical. But even then, people will go pale after a degree of anemia. So hemoglobin need to be examined all the time, or anemia need to be determined by level of hemoglobin, MCV, which mean corpuscular volume, and by reticulocyte hemoglobin, and the third is by peripheral blood film. Okay, the MCV, which is mean corpuscular volume of the RBCs, is either smaller, what we call microcytic or microcytosis, or big, what we call macrocytosis. Okay, and this can easily be seen and measured by the new techniques, auto techniques, which can give you a big macrocytes, and in folic acid or B12, you get macrocytosis with normalization of the cell. But in iron deficiency anemia, you get micro, which is more microcytosis with hypochromia. When I say chromia, it means the hemoglobinization of the RBCs. So these are the measures which are very easy now to do, and we can do it easily in any decent laboratory. Okay, the causes of anemia is, if you just go through the diagram we already made, is the bone marrow, erythropoietin on top, stimulated, you need the nutrients, you make the RBC. The RBC has to live 120 days. If it breaks before then, this is what we call hemolysis, hemolytic anemia. So it has to live the 120 days. If it breaks before the 120 days, then this is hemolysis, and the bone marrow will take up the recycle of the recycle of the products or the nutrients. Okay, you have to make a difference between anemia due to acute episodes. Like if you vomit blood, massively, then you obviously lose blood, you lose hemoglobin, you become anemic. This is not a worry for a diagnosis, because it's taken up by another system, which is hemodynamic. Because if you vomit blood a lot, then your hemodynamic status will be disturbed, your pulse will be rapid, your hemoglobin will be dropped, and you may be in shock. So here, the anemia is, secondary to the hemodynamic disturbance, and people rush to replace blood, and maybe if you don't have blood enough, you give mannitol, which will raise the hemodynamic status or raise the the level of blood pressure. So that is one important aspect. You differentiate between acute and chronic anemia. Okay, chronic anemia may be insidious. It goes on like, if you have a loss of blood, say from hemorrhoids, okay, then that will not show itself like an acute episode. It shows itself in the chronic form. And the chronic presentation of anemia may be lethargy, it may be in children, cognitive function, they don't do well in school. You feel fatigued, easy fatigue, and if you hurry up, you get breathless and you get palpitation. And this is a compensatory mechanism because low oxygen, low hemoglobin is low oxygen, and this is need the heart to work harder to deliver more blood, okay, to compensate for the loss of hemoglobin. So these are the symptoms, and in children, severe anemia can result in heart failure. Severe anemia can result in heart failure. So, in general, what are the causes in tropical countries of anemia? The first one is obviously nutritional. Okay, that is very important. Iron, folic acid, and maybe B12. These are deficient, and vitamin A. So if these are deficient because of poverty or malnutrition, then children can become anemic. That is the nutritional part. And here it will be part of another syndrome of malnutrition. You may have skin changes, you may have angular stomatitis, you may have glossitis, other features of malnutrition. And this is correctable. And it needs care, good health system. Number two, infections. Malaria is notorious of causing anemia, especially chronic malaria. Patients who gets repeated attacks of malaria are always anemic. Okay. Thirdly, HIV/AIDS. In HIV/AIDS, all the patients are anemic, and anemia is up to 60% of all HIV patients are anemic. So infection is important in formation of anemia, particularly in tropical areas or in Africa. The other causes is worms. Among worms, the classical one is Ankylostoma duodenale. Ankylostoma duodenale is a nematode which lives in the upper intestine, but hooks to the anchors itself with teeth into the mucosa, thus causing bleeding and loss of blood, and it takes blood, sucks blood to live. So both ways, it causes iron deficiency anemia, and it is important to think about it. Other worms are possible, like Ascaris causes malnutrition, okay, or low status of the body. Trichinella also causes anemia. So deworming program, which we talked about, the deworming program is very important in a lot of areas where there is high prevalence of intestinal worms, be it Ankylostoma, which is the classical cause of anemia, or the other worms in particular. Schistosomiasis is another one cause of anemia, as loss of blood in Mansonis through the colon and hematoma through the urine, but because of chronic infection. So these are some of the coverage, the clinical coverage of anemia. And in chronic infection, there are certain chemicals which can occur preventing iron absorption. Okay, so we have what we call the chronic anemia of chronic infections, anemia of chronic infections. So who are more prone to develop anemia? Number one, obviously, pregnant ladies. We always care about pregnant ladies because we are caring about two persons in one person. And whatever happens in the female, reflects on the child, on the intrauterine child. So if the lady is anemic, the baby will be consequently anemic and will be premature, small, and needing care. Okay, anemia is very common among pregnant ladies. And if you talk about worldwide pregnant ladies, you will find at least 50% of all pregnant ladies are anemic, are some sort of anemia. Because the demand on nutritional status is high, unless if there is care, like in family medicine or health centers, these ladies should be cared for by examination of chronic diseases like gestational diabetes, hypertension, but so far okay by iron supplement, iron and folic acid supplement, and both of them will care about or cater about anemia. But folic acid has an additional benefit because it prevents neural or neurofetal abnormalities like spina bifida. So folic acid is necessary to be given, as well as anemia, as well as iron, to prevent the anemia. What is the normal hemoglobin? WHO has charted the normal hemoglobin. In males, it's 12 grams per deciliter. In females who are not pregnant, will be males are 13 grams. Okay, then it goes non-pregnant ladies will be 12, and pregnant ladies will be 11. Okay, why is it accepted lower in pregnant ladies? Because there is hemodilution. Okay, in children, those who are prone to anemia are those who are premature or small for size. Here, this is a reflection of the intrauterine growth. So the amount of blood volume of the child, the weight, is directly reflected to the hemoglobin content of the body. So if the baby is small, all right, or premature, then it's very likely to have anemia. And this can be corrected by caring about the pregnant lady, all right, by giving them enough iron. What do we do usually? There is a trick when the baby is delivered, you delay severing the cord or clamping the cord for 2 to 3 minutes. Okay, so that more blood from the placenta will come to the baby. It's only 2 to 3 minutes, but it is significant. So it's the child has to be, if it's fed for 6 months, the first 6 months by breast milk, it's okay. But cow's milk, if given to neonates or to young infants, cow's milk has very little amount of iron, and it may even causes iron losses. So the children is when they come to adolescence, the demand from iron is 10 times per kilogram body weight. So the demand is high. The demand is high in maternal, in pregnancy, and when the children are growing. Okay, the bone marrow can be a cause of anemia naturally, because this is manufacturing area. The what causes bone marrow dysplasia or myelodysplasia? Number one is the bone marrow stores ferritin, and as we're going to see in the laboratory, ferritin is the most diagnostic indicator of iron deficiency anemia. Okay, so if the stores of bone marrow, of the iron in the bone marrow, then that is the start of anemia. But till the stores are finished, okay, then anemia will not appear as microcytic. So hemoglobin will go down and the microcytic will go down. So once the microcytic anemia of iron deficiency appears, meaning that anemia has been going on for some time before it appears in the peripheral blood. So what are the factors which will cause iron deficiency anemia? Because by and large, the most common cause of anemia is nutritional, is iron deficiency anemia. So we have inorganic iron changed to organic iron by the acid in the stomach to get absorbed. If there is diminished intake, then you'll get iron deficiency, logical. And you find iron mainly in meat and liver. Cow's milk has less iron. Vegetables and fruits are rich of folic acid, not iron. Okay, so iron, once it is changed from inorganic to organic, get absorbed through the intestine. We need not only the acid. So if you have achlorohydria, which is no acid or less acid, then the transformation of inorganic to organic acid absorption will be decreased. Vitamin C needed for hemoglobin, mainly because it can help transformation of inorganic to organic. So we need acid in the stomach for iron absorption. Number two, we need to have the iron absorbed without chelation. Chelating agent means that there is another substance which binds to iron, make a solid combination and take it down to the feces without being absorbed. And this chelation is what we call phytate, which is present in some cereals, in some vegetables. These phytates will decrease the absorption of iron through binding or chelating the iron. Milk, again, will cause such chelation, especially if you have calcium, high calcium, antacids, because they neutralize the acid. Again, they decrease absorption of iron. Okay, and then drugs, certain drugs, particularly tetracycline, is known to chelate the iron chelate the iron and decrease absorption. Okay, so clinically you can diagnose anemia by pallor, but it's an insensitive way of telling what is the hemoglobin like. As you said, if you have severe anemia, you will have the pallor, and if it is a chronic iron deficiency anemia, chronic meaning long-lasting iron deficiency anemia, you will get either flat nails or spooning, all right, with ridges, all right, longitudinal ridges, and the nail will call, this is a syndrome called colonychia. But it doesn't occur in iron deficiency anemia of the acute onset, but it is found in disturbed iron in long-standing iron loss. Okay, what is the in the stomach? What happens? What decreases iron absorption? Okay, number one is H. pylori infection. H. pylori, which is the infection of the stomach. We already said that this can lead to decreased absorption and acids, fatigue, all right? And then there is malabsorption. You have malabsorption, you malabsorb everything, including iron. And lead is very often quoted in the books that lead will cause iron deficiency anemia because it disturbs absorption of iron. It shares a common pathway for iron, so it competes with iron for absorption. And there are peculiar substances which can cause iron deficiency anemia, like pica, eating mud. Okay, this is not uncommon in children. Paint, even paint, out of the walls, if people or children lick the paint and cause iron deficiency, and even a lot of ice will cause anemia of iron type. Okay, but this is can be diagnosed easily. All right. So, how would we investigate? How would we investigate iron deficiency anemia? Okay, serum ferritin. Let us talk about serum ferritin, which is the most useful laboratory measure of iron status. Okay, the serum ferritin. It's a protein. It's an acute phase protein, what we call acute phase protein. So it may go up in inflammation or malignancy. But otherwise, apart from these precautions, it's the most important diagnostic criteria. Ferritin low is it's anemia, it's iron deficiency anemia. What about serum iron? Serum iron represents iron coming and going in the serum. Okay, so it is an indication, but not a perfect indication. We have what we call total iron binding capacity of the capacity. Iron is transformed by transferring. Okay, so the iron bound to transferring, the capacity of it can be measured. If there is little iron, the capacity will be high. So if you have high capacity, raised capacity of iron binding, then this is again a sort of a very important test for anemia. And then we have reticulocyte hemoglobin content. And this falls within days of iron deficiency anemia. Call it again, reticulocyte hemoglobin content. Reticulocytes are the premature cells which comes at a stress bone marrow. And the content of the iron, of the hemoglobin in that will be less. If you are in doubt, then you can do bone marrow. And bone marrow can be stained for iron. If it is store is less, then it is iron deficiency. And there are certain anemias which is called sideroblastic anemia. So we have sideroblasts, and the stain is Pearls. It's P-E-R-L-S, Pearls stain. And this will show the sideroblasts. Sideroblastic anemia is a replacement. A patient is living in the bone marrow, the sideroblasts, and it can cause iron deficiency anemia. This is some of the tests. And simply, if you have a hemoglobin, which is low, easily, and then if you have a reticulocyte hemoglobin, if you don't have a reticulocyte count, you have to have a good peripheral blood film. And the good peripheral blood film will show you the microcytic hypochromic anemia, hypochromic cells, which is the cells which shows the chromic is the hemoglobinization. So in contrast to folic acid or B12 deficiency, this is macrocytic anemia, and the bone marrow will be megaloblastic. So big megaloblasts, which are the precursor of the RBCs. Okay, so it's megaloblastic anemia, folic acid or B12, and microcytic hypochromic anemia of the bone marrow. So the importance of diagnosing of anemia is essentially on treatment, because you cannot assume that this is iron unless you diagnose it iron deficiency and then you start replacing iron. But you cannot do this unless you know the exact basic pathology which have caused iron deficiency anemia. And this requires some investigation. If it is clearly iron deficiency, you go through the diet, if it is sufficient with iron or not. If there are any habits like sucking lead from sources, pica or paint, this is in children. Exclude worms, because this is again one of the major causes or good causes of anemia in tropical countries. And then you will look into possible blood loss, chronic blood loss, because overt hematemesis or vomiting of blood is very clear. But overt or hidden causes, like, if it is piles, you can bleed from piles, small amounts every day till you become anemic. In reproductive life of females, menses or menstruation is a very good cause of anemia, because ladies may not appreciate that the menses is too long or too heavy, okay, because they have no experience. So that has to be questioned, the amount of blood which is lost in each menses, and has to be replaced by iron therapy. Gastrointestinal bleeding, again, you may have an ulcer which will give an epigastric pain and leaks blood. And if it leaks blood, the stools will be black, very offensive, okay, slimy, and this is what we call melena. Melena is very black stools, very offensive and slimy because of the albumin covering the stools. So that's another cause of bleeding. You can bleed from a polyp in the colon. Okay, a polyp will have no symptoms, but it bleeds. If it bleeds, then that will be a cause of chronic iron deficiency anemia, loss of blood. Okay, again, if you have a small polyp in the cycle or bladder, then it may bleed slowly, giving you blood in the urine. But blood in the urine is usually overt. That can be seen. Okay, unlike blood in stools, especially people who have pit latrines. Pit latrines is a well where you defecate in, you don't see the stools. Okay, so this is another area of blood loss. So ask about a lot of these symptoms to see if you have there is blood loss, and this will give you cause of anemia. So all the time, try to find the cause. Anemia is a secondary presentation. It's a secondary presentation of an underlying cause. So if you are asked about your patient, they'll say his diagnosis is anemia, because this is not enough. It's not even enough to say anemia due to iron deficiency. It's not enough. What is the cause of the iron deficiency? So unless the iron deficiency is diagnosed as where the loss of iron or where the deficiency, then you will not treat the anemia properly. Treatment. Treatment depends on the cause. Treatment depends on the cause. If you have, a bleeding site, you have to correct it. Even polyps in the colon can be, snared, taken out. Peptic ulcer nowadays is very, very easy to treat if you diagnose it early. If your patient is unfortunate to have carcinoma of the stomach, it has other symptoms apart from the anemia. If you have ulcerative colitis, which is ulcers, multiple ulcers in the colon, again, it causes anemia. Obviously, parasites has to be excluded. So it is important. So after that we will suggest that you replace the iron. How do you replace iron? Either by oral tablets, or by IVIM. Iron can be given orally, can be given through IM, which is intramuscularly, or can be given IV. We don't resort to parenteral. IV and IM is called parenteral. We don't resort to it except if we need a quick replacement of iron. Okay, so if we do the IV, you have to be careful about not raising, not in allergy, which can occur with IV iron. But normally, we rely on oral iron therapy, which is iron sulfate or ferrous sulfate. Tablets is usually about 20 to 100 milligrams and can be taken orally. I usually prefer oral therapy and in a continuous way. Some people will not tolerate the tablets. Okay, they have dyspepsia or some pain. If you trick it into another salt instead of sulfate, to fumarate or sucrose, salt, then the stomach may appreciate the tablets and will settle with it. Or glycinated ferrous, again, is another way of avoiding unfortunate tummy pains which may occur with iron sulfate. So the first thing, because the stores has been depleted from the iron, you have to give iron, and you will not show great evidence except after 4 weeks. Because you have to saturate the stores, and then it appears, the normal RBCs will appear, and then you have to continue to replenish the losses for at least 3 months, having controlled the source of iron deficiency. Okay, so for iron deficiency, you need to have a cover 4 weeks, and then you will see good effect, and then you will continue for three months. 3 months of therapy. That with eliminating the cause. In pregnancy, we prefer to give iron and folic acid daily for the period of pregnancy, and here we'll ascertain that iron is given enough. Folic acid again is needed, and as we said earlier, it helps neural defects like a spina bifida if you give folic acid. Here there is a challenge. You have to get the pregnant ladies. You have to get them. This is how the importance of family medicine and the importance of primary health care. We have to provide the medicine to women near their houses. This is primary health care. Okay, and this is what we have been trying to do in Sudan, distributing the health centers all over the state of Khartoum to make the pregnant lady, who is usually a housewife, burdened by children, burdened by cooking, burdened with a lot of responsibilities of the house. If you ask her to go to the center of Khartoum, for instance, to get antenatal care, which is examination of the baby, maybe ultrasound and hemoglobin and urine. This is covers the antenatal. If she takes a bus, expensive, she wastes one day to see a doctor or a midwife for half an hour and then come back, then she usually feels tired of going there. But if the health center is very near, women can go there easily. Even if they are cooking, they can just put the fire down and go and get the care. If the iron therapy, folic acid, and they come back. So it's important to shorten the period, shorten the distance, and make it available to the women. So women should be cared for by iron therapy and folic acid. Okay. If there is infection, it has to be treated. Obviously, if there is an H. pylori infection, then it has to be treated properly. If there is worms, if there is HIV, if there are any other causes of iron deficiency, it's important. The vulnerable sector of the population is children, premature children, adolescent children, children living in worms, okay, and pregnant ladies. So these are the message of today, which will be causing the anemia. Okay, we have about 7 minutes or so. We can go into folic acid. Folic acid is a vitamin which is present in green vegetables and fruits. Okay, fruits. The defect of folic acid, it may be, as I said earlier, it may lead to fetal neural defect. Okay, folic acid, chronic deficiency of folic acid can also result in atherosclerosis and can result in arteriovenous thrombosis, and there is some evidence that it may even predispose to colonic cancer. So folic acid is needed for maturation of the RBCs, needed very much for the formation of the RBCs. Okay, and it is important in the formation of DNA. It is important in the carbon transportation, which is necessary for the DNA. So the DNA biosynthesis is dependent on folic acid. This is why if you lose folic acid, you can get anemia of the macrocytic type, megaloblastic. Okay, who is more vulnerable to have folic acid deficiency? Alcoholics, alcoholism. Okay, pregnancy again is because of the high demand, malabsorption. Okay, malabsorption, and excessive cooking of vegetables. Okay, vegetables may have high folic acid, but they lose it if you excessively cook the vegetables. Okay, it can cause anemia. And how do we measure it? We measure it by serum folic acid, but it is not a reliable. It's not a reliable sensor, and we measure red cell folic acid. If you have a deficiency of folic acid, you lose serum iron folic acid quickly. But the store in the red cell folic acid is there. Okay, so the store is there, and you lose it gradually. So the more sensitive measure of folic acid is red cell folic acid. If that is deficient, then you have a real deficiency of folic acid anemia. Okay. Vitamin B12. Vitamin B12 is contained in meat and liver. Okay. Vitamin B12 has a very interesting way of being absorbed. If you take vitamin B12 from meat and liver, it goes in, it changes it breaks, then it combines with an intrinsic factor produced from the parietal cells. And this will make a combination. Okay, intrinsic factor from parietal cells and the food or dietary B12, they combine there and they go down. Where is it absorbed? It's absorbed in the terminal ileum. The terminal ileum. Okay, there, and then they go and get stored in the liver, all right, and then used in the bone marrow to complete the formation of the RBCs. Okay, B12. So B12 can be deficient if there is less food or malnutrition, or if there is parietal cell disease like achlorhydria, okay, or pernicious anemia. Pernicious meaning malignant. It's not a malignant in the sense it's cancer, but it is bad because you get pernicious anemia, which is an important cause of B12 deficiency because of lack of intrinsic factor which is produced by parietal cells. And this you can give a total B12 by injection for life. There are certain diseases which will affect the terminal ileum. And if there is like Crohn's disease, if you have a tumor in the terminal ileum or cecum terminal ileum, okay, or it's been removed, the terminal ileum being removed because of cancer of the cecum, then you will lose the terminal ileum. And if patient loses the terminal ileum, he has a syndrome called terminal ileopathy. The terminal ileum is not a site only for absorption of B12. It's also a site of absorption for bile salts. And this is God's blessing in that we are recycling our substances so that we can survive. So bile comes from the gallbladder into the common bile duct in the intestine, causes emulsification of fat, and then goes down. And instead of going to the colon, it goes bypassing, it goes to the ileum and then get absorbed. Very little goes to the colon. It goes reabsorbed into the liver, giving you a recycle and preserving the amount of bile salts production. If you have a terminal ileopathy, which is diseased terminal ileum or removed terminal ileum, you will get bile salts wasting. And bile salts is a detergent. There's some detergent, okay? And it affects the colon, sloughing of the colon, causes mucosal sloughing and a diarrhea, a whitish diarrhea, what we call choleriac diarrhea of terminal ileopathy. Just like cholera. Cholera, you remember, is rice-like color of stools in cholera. This is why if the bile passes a terminal ileum because of disease or absence of the terminal ileum, it goes in the colon, it causes sloughing, and it causes diarrhea, what is called like terminal ileopathy, choleriac diarrhea, or diarrhea which is very, very much like cholera. Okay, so that's B12 which is needed. So iron deficiency, microcytic hypochromic anemia, B12 and folic acid is megaloblastic, is macrocytic anemia, okay, and megaloblastic bone marrow. These are the essential factors which are needed for, and you can work it out, where they are found in the food, how can they be deficient. Okay, vitamin A is also needed for formation of hemoglobin. How? It helps erythropoiesis, okay? It helps erythropoiesis in the bone marrow. Erythropoiesis is formation of RBCs in the bone marrow. It enhances iron absorption, and it enhances release of iron from the stores. So vitamin A is important. And it has been shown in a lot of studies from Thailand and from even Tanzania, if vitamin A is being given to the children for xerosis, for the eye problems, okay, and without giving iron supplement, the hemoglobin rose of all the children. And this is why we said early in the lecture that hemoglobin is an indicator of health. And that has proven that vitamin A is also needed for good hemoglobinization of the RBCs or good production of RBCs. It helps erythropoiesis, it enhances iron absorption, and it enhances release of iron from the stores. So consequently, it increases the hemoglobin content of the RBCs. So that is about anemia, and just a short summary of anemia and how it relates to the tropics. So think about factors which are influencing RBCs formation, either the nutrients or deficiency of nutrients, loss of blood because of infection, loss of blood because of worms, loss of blood because of schistosomiasis, and then the others like ulcer, polyps in the colon, hemorrhoids. These are shared between the affluent world and the African world. So with that, I would like to thank you very much for being with me. And these lectures are now uploaded in the YouTube, and you can refer to them every time if you like. And then hopefully it will be useful for all medical students all over the world. Thank you very much indeed.